So welcome to the refractive session, which we are basically going to solely focus on lenticule extraction. My co-chairs and I, we have designed this program so that it's a little bit more of an interactive, I wouldn't say debate, but a bit more interesting format. So as you all know, refractive lenticule extraction is now performed in a variety of techniques. We have different technologies available, and of course these technologies are developing at different speeds. So we have a really distinguished panel of speakers here. Just a full disclaimer, I think most of us on this panel use different technologies and different platforms. So we're not here to promote one single platform, but we do want to have an open and honest debate about the pros and cons and each technique. So without further ado, shall I kick off? So I'll kick off by introducing our first speaker, who's going to give a broad overview of KLAX. Okay, so Professor Sun Chisan, or Arvin, is basically the president of TSCRS, and he's going to give us a little bit of an overview of what we're going to talk about today.
Thank you. Thank you for having me in this section. My talk today is the history and evolution of keratoid lenticule extraction surgery. I'm teaching some from Taiwan. I have no commercial interest in any product mentioned in my talk. Here's an outline of my talk today. Oh, sorry, too fast. Okay. So as you know, the LASIK is an excellent excimer laser procedure that achieving 40 in corrected visual acuity, 99.5% of patient, and with a very good refractive predictability, 98.6% of patient within one diopter. But there is some main need of the LASIK procedure. For example, the flap-related complications, corneal nerve injury, biocommunication issues, and the long-term uncertainty of this procedure. So there is long-term debate of where we should go back to the surface with the surface ablation or step deep in the lenticule extraction. Let's go back to the 1989. At that time, Stanley take advantage of the ultra fast waves that create the cavitation bubble and to dissect the corneal tissue. With that, 1996, Ido et al. Used the picosecond laser, but at that time still requires significant manual dissection leading to irregular corneal surface. But later on, this issue has been resolved by the use of the femtosecond laser. The difference between the flex and the smile procedure lies in the corneal wound they created. Different in 2011, the smile procedure come to the market with a very small corneal wound. So this is the prototype of the VisualVax femtosecond laser system. We first create the back surface of the lenticule, followed by anterior surface and the saccade, and then open the wound to take off the lenticule. So the differences between the prototype and later on the smile procedure lies in the very small wound, just 2 to 3 millimeter with a smile procedure. So we can take it out very easy and smoothly within the corneal stroma. Since then, smile procedures again is popularities from 2010 till 2020. There is an increase in publication per year. Most of the publication from China, here you can see from 2014 onward, China still published the large number of the refractive surgery smile procedure papers. But what have smile achieved? According to accumulated evidence, our moderator Marcus also published a paper in ophthalmology. There's similar safety, efficacy, and predictability between these two procedures for 1 month, for 1 year follow-up. However, some study indicate a better predictability of LASIK procedure, and in some cases of the high astigmatism, smile tend to be undercorrected. How about the high order aberration? Max published and showed that there is no significant difference, but other studies point out that higher spherical aberration in femtosecond LASIK patients, but the higher vertical coma in smile patients. It's very interesting to know, even you said it a very similar, the same optic zone, but smile patient reaching a larger functional optic zone compared with LASIK procedure. So the sphericity after surgery, the SMILE procedure tends to better preserve the corneal sphericity than LASIK. How about the corneal biomechanics is what we are concerned the most. With the ocular response analyzer, this meta-analysis shows that SMILE seems to be better as compared to the femtosecond LASIK or LASIK procedure. But with the COVID, there is no enough data to document the superiority of the SMILE procedure as compared to LASIK. There is some argument about the earlier stabilization in SMILE patients. Some study point out that especially the LASIK procedure, there is a greater corneal epithelial remodeling, but on your left, this paper published in 2019 cornea. In a 2-year follow-up, there's no difference between these two procedures. One of the merits of the SMILE procedure lies in that it takes advantage of the smaller corneal wound, so less disruption of the corneal nerve, and then it turned out shows to be the better superior outcome in terms of dry subjective and objective parameter. Even more in 1 month after this procedure, you can find the difference of the osmolarity difference. So the corneal sensitivity and nerve density, SMILE procedure turned out to be more rapid recovery of the corneal nerve and more corneal nerve sensitivity preserved. This meta-analysis also demonstrated SMILE procedure seems to be superior to femtosecond laser in terms of subjective and objective parameter, even 1 week after the surgery. Here you can see the difference between the corneal sensitivity. So how about the interleukin-6, the NGF? This is a growth factor inflammatory cytokine, tend to be more in LASIK procedure as compared to a SMILE procedure. This is a paper published by John Mesa's group. Also point out that more NGF and substance P production in the LASIK procedure, it indicates a more intense stroma wound healing process. How about long-term comparison of nerve parameter in SMILE LASIK? Although these two procedures damage the corneal nerve and never return to normal, even after 5 years follow-up, but here you can see the more nerve preservation in SMILE procedure compared to LASIK. So here is a short summary of these two. Because of the stroma inflammatory and wound healing response was more intense in the LASIK procedure, probably disrupt the integrity of keratocyte and plus the truncation of subbasal nerve plexus. So the SMILE seems to be better in terms of dry outcome. But is SMILE really good? We should also pay attention to the learning curve of the SMILE procedure, especially for the initial cases. Some cases like suction loss, epithelial defect, or opaque bubble layer, they occur as compared to the consecutive cases. Also, the absence of cyclotorsion compensation. So point out that some have the highest cyclotorsion, maybe up as high as 9.5 degrees after surgery. Because of the lack of the automatic centration method, we should very pay attention to the angle kappa adjustment, because if we don't pay attention to it, maybe it leads to inaccurate and high astigmatism correction in SMILE patients. Also, because there is no built-in wavefront optimization, so SMILE procedure may be problematic in significant high-order aberration on irregular cornea. Also, their study indicated greater loss in corneal volumes, which would limit the extent of corneal correction in SMILE patients. And less wall effect as compared to LASIK has been pointed out to our patient after surgery. So there are some mainly in first-generation cataract surgery, as mentioned above. So the concept of low energy was introduced to the market because the surface recurrence index decreased as the pulse energy increased. So did better visual outcome like the modulation transfer function or high order aberration, and the corrected visual outcome and the corneal aberration with the low energy concept of the SMILE procedure. So energy was significantly associated with postoperative log-mark VA in different models. Here we can modify the energy by the function of the focal length and the wavelength of the laser. So there are some issues that be pay attention to, but some of these can be resolved, some of these are not. Here are second generation Calyx machine on your on your left, this is the VisualMax 500, but on your right, the 4 is also on the market. We can see here the lowest energy, 40 to 50 nanojoule in the Johnson & Johnson Elita system, so the higher laser pulse frequency. Also, the bi-convex model is different from the other three. So the second generation Calyx, we should this machine, they pay attention to what the caveat we just point out, but still the waveform optimize is not fully addressed in this new machine. So the future direction procedure should be expanded indications such as hyperopia patient or integration of the advanced image like a waveform or real-time corneal mapping. Also, the personalized treatment like the tailored surgical parameter based on the corneal biomechanics, and in the future, we hope that AI-driven data analysis can help us to optimize the visual outcome, reduce the complications. With that, I invite all of you to attend this June's TSCR Plus, the third Global Young Observation Summit, which will be held in Taiwan, Taoyuan, the vibrant city of northern Taiwan. Thank you very much.
Thanks very much, Arvid. That was great. So that really sets the stage with a quick overview and summary of the evolution of Calyx. Obviously, we have an incumbent technology that's been first to market, but obviously now with so many different technologies, what we really wanted to do is to go through in more detail each technology. And I think I really like Arvind's slide, which shows the unmet needs from the first generation of Calyx, and how each technology, each of the speakers hopefully will touch on how each of the technologies tries to overcome these unmet needs in the second generation Calyx. So to kick things off, maybe you want to introduce the first speaker?
Hello. Yeah, thank you, Marcus. Yeah, so as we said, now we have a beautiful history and evolution. Now we're going to go to the first of these options, which is the Smile Pro. Is it the future of the CLEX is what we want to know. And to deliberate on this, we have Dr. Achal Gupta from Australia, and she's going to discuss about her experience as well as why she believes that this is the go-to procedure. Over to you.
Thank you so much, in particular to Marcus for inviting me to speak at this session. I definitely have the easy job of talking about Smile Pro and why that is the future of Calyx. I have no financial disclosures as related to this talk. And as the previous speaker has already done some of the heavy lifting in terms of explaining what Smile, which has pretty much for a long time up until recently become synonymous with any lenticular extraction technique. So that's really the history behind the procedure. And Smile Pro is, I guess, the next generation in this lenticular extraction technique. So why Smile Pro? Well, between Smile and Smile Pro, there's been over 10 million cases. There's, evidence for its efficacy. It's been proven over and over. What we now have is central line and oculine, the speed of the laser, the lack of suction loss, and the patient experience are some of the points that I will go through in talking about why this is the future of Calyx. So this was in celebration of 10 million cases with Smile and Smile Pro towards the end of last year. So it definitely has a very long track record. There are some significant differences between the 800 and the 500. In particular, the size of the machine. So as you can see, it just fits very neatly into my little waiting room en route to the laser room prior to installation. So it's got a very small footprint. And in terms of, the patient experience and also the surgeon, you don't have to move the patient or yourself. You've got the swiveling operating arm and the laser arm, and it just makes for a very seamless experience. It is 4 times faster, so we can do treatment times in less than 10 seconds. We have oculine and central line, which I will go through as well. There's a lot of evidence behind SMILE now, and I'll call it SMILE still, even though we are talking calyx. In terms of its equivalence to LASIK, less higher order aberrations, perhaps slightly less refractive predictability, but that will hopefully improve with the next generation with cyclotorsion and centration control. In terms of outcomes on the 800, this has also been shown in some individual surgeon case series as to be very good and equivalent to LASIK. And this is a slightly sped up video, but it's an extremely fast laser cutting time and a very easy delineation. You don't want it to be too easy. This is something that we will talk about in terms of optimizing your energy, but certainly a really great view with the microscope on your laser, and it's all done in seconds. So it makes for a really seamless experience for the patient. This is a little video of how we do the centration alignment. So you have your visual axis X and Y inputs into the 800, and during your docking, you have the blue dot guiding you as to where the corneal vertex is. And subsequently, you can also now have automated cyclotorsion control with input from the AIOS 800. Yes, the AIOS 700. Too many 700s and 500s. And that allows for you to match the iris image from pre-op to intraoperatively, and this is sort of a live view of how that happens. So you don't have to worry about cyclotorsion of the eye as the patient lies down. In terms of suction loss, because of the really short treatment times, we know that most of them are related to the Bell's reflex, and most of them occur after the initial 10 seconds, so it's extremely low. And it is different for different surgeons, so there's no real point in talking about it too much here. But with that low suction loss, you are really minimizing issues with creating false planes or some intraoperative complications as related to that. There's a lot of workflow efficiency, and in some of the work done by Dr. Sri Ganesh and Dr. Bra, the patient experience in a contralateral eye study was better on the 800. So that's really interesting because that's really just coming from the patient directly. And there's some clear differences. So we're not just talking about treatment times, but also suction time that the eye is under. And I think that is very relevant in terms of what you see with your patient. No subconch hemorrhages with a corneal applanation. And of course, the treatment time being the shortest of all the different second generation calyx lasers. There is some evidence to show that perhaps smaller spots closely together with a lower energy leads to better visual outcomes day one. I did do a study looking at this and comparing the two bubble patterns. They were quite similar for us, really lowering the energy as much as we could for each of those settings. And there was a slight trend towards better vision day one in the narrow spot spacing group. But this was not statistically significant. So there was some difference, but not significant. Our current settings allow us to be about 75% of patients 6/6 day one, and I think we can, still kind of optimize that as we go. But at month one, there's very little difference, and I guess that's really important as well in terms of the patient's actual final outcome. In my hands, the lenticule extraction time did not vary, regardless of what the bubble pattern or the spot spacing pattern was. And there are some other advantages of the Visumax 800 as well, of SMILE Pro, which is you do have some different user interfaces. So for small eyes, it's a bit easier. You have a live view of the eye during surgery. It's very quiet. Patients do love that because they don't like the loud buzz from the eczema. We have very fussy patients in Australia, obviously. And you have the restart options as well as circle for enhancement. This is something that I didn't come to appreciate until I had my own practice, but the connectivity that you have with your diagnostics and the laser, you can now plan your treatment remotely, and you have your diagnostic parameters directly inputted from the IOL Master 700, and you can export that data to your 800 Visumax. And that leads to a lot of reduction in transcription errors, and I think that's really, really helpful. Plus also you have the nomogram service and the ability to create your standard graphs for publications and things if that's something that you're inclined towards. Currently, Smile Pro is the only platform on which you can do hyperopic treatments. And I think there's a lot more work to be done, as the previous speaker alluded to. So in summary, why Smile Pro? Well, you have excellent visual outcomes. It has the longest track record. It is currently the fastest procedure time, low suction loss, and really the best patient experience. So for surgeons seeking efficiency and accuracy with something that has long-term proven safety and efficacy, and you want a laser that has it all, go Smile Pro. Thank you.
Wow, that's great. Fantastic. That's a good start to the debate. I think you made it very difficult. We'll do some discussion after we've heard from all the speakers. So next up we have Clear. So Dr. Ramya Sampath will try and convince us that Clear is probably the future of KLX.
So good afternoon. I'm here to talk to you about Clear. Thank you all for giving me this talk. A customary slide to talk about the conflict of interest and the disclaimer. Before going to the topic as such, Clear, a small history about the femtosecond lasers. Even before the CLEX procedures come, we've been used, the ophthalmologists or the refractive surgeons were looking out for ways to come to the present conclusion, and they've been working with nanosecond lasers, picosecond lasers, and the shift to femtosecond laser was a big relief to them. And with that, the low-energy intrastromal refractive surgery from 1991 has been a big game changer in refractive surgery. So the Femto LDV ZIMA platform has been commercially available since 2005, and the CE approval for the CLEAR program is available since April 2020. And as we all know, CLEAR stands for corneal lenticule extraction for advanced refractive correction. So why is CLEAR best? I'm here to talk to you about why I would prefer Clear more. For the unique design of the handpiece, which enhances the short working distance, which has its more advantages. It offers a low pulse energy and overlapping spots, which enhances the smooth dissection. Why is low energy concept needed here? And before that, how come ZIMA adapted to this low energy concept? By two ways. One, shortening the pulse duration, and second, reducing the focal spot size. When we have a very low pulse or a decreased pulse duration, it's natural for the cutting process of the laser to be very slower. So they incorporated to do a higher repetition rate, which even goes up to 20 megahertz to match the current speed. And with the focal spot size, this is all based on the Gaussian beam and the Rayleigh length, where to talk about the ideal focal spot size, ensuring a smaller energy threshold, which is obtained by increasing the numerical aperture. So how again? The larger numerical aperture is again got by either increasing the lens diameter to make it very bulkier, or you have to position the focusing optics quite closer to the eye. So ZIMA again adapted the latter approach, where it enhanced the shorter working distance to bring in the ideal focal spot volume. Again, why this is important? So when the femtosecond laser and tissue interaction, which happens to be with high pulse energy, it results in mechanical forces applied to expanding bubbles. So you have the plasma bubbles expand more than the radius which is intended to. So when it happens to do with the low pulse energy and with small spot size and overlapping plasmas, there is no need for a secondary mechanical tearing effect, and the high pulse repetition rate increases the cutting speed. So when it is with overlapping spots, small focal spot size, it results in an excellent stromal bed quality, having a very smooth lenticular extraction. And with the confocal microscopy, this is how the anterior and posterior surface of the lenticule looks. And again, why this is important for us to talk about the postoperative haze, apart from the surgical manipulation on table. This plays a vital role for us to talk about the postoperative healing, which has a bearing impact on the vision. An ideal femtosecond laser cut will have a uniform laser pattern with tiny non-fluid laser plasma, which will have a homogeneous cut, which is achieved with this kind of laser. Advantages of having a low pulse energy is it has less collateral damage and improves in faster wound healing. And the patient interface, which is used in CLEAR, is kind of a very flat PI. So this is how which engages over the cornea. When we have a flat PI which causes a corneoscleral suction, the better control over the patient eye movement is there, and eventually there is no suction loss. And the pressure which increases up to 700, I think the company is currently working to decrease it, which will be out soon. And the surgical steps with any CLEX procedure remains the same. You have to dissect the anterior and posterior surface of the lenticule and extract the lenticule through the incision. When it comes to CLEAR, in what way it is advantageous? We have the centration options. There are 3 centration options. We talk about the pupil center, fixation, light, and the corneal marking. And the biggest advantage here is you will be able to recenter even after docking without the need to release the suction. This plays a vital role for us to ensuring an efficient surgical flow. Why is centration important again? Because decentered lenticule causes an increase in coma, which decreases the visual acuity postoperatively. Apart from that centration, we do have the alignment for the cyclotorsion compensation, which happens with high cylinders. Ideally, prior to the surgery, 0-180 degrees should be marked at the slit lamp, which can be extended on table. And the alignment again can be done using the touch screen without the need to release the suction again. This is how the cyclotorsion compensation can be aligned. And so the trickiest part when you deal with the lenticular extraction is the identification of the plane. So a lot of times the beginners end up having misdissection of the planes. So the CLEAR has a very useful tool of multi-incisions and having a guiding tunnels to make the beginners or learners have a very wonderful surgical experience to do a CLEAR procedure. So we can plan the tunnel incision 1 or 2 depending upon the surgeon comfort, and the position can also be optimized, and the guiding tunnel will guide to the anterior and posterior surface of the lenticule. This is another good feature with CLEAR, where it has the OCT for us to verify whether the lenticule which is being formed is well within the applanated area, and the incision can also be adjusted again when it is on docking. It can also be adjusted to make sure that it is also at the applanated area. To summarize, the flat PI and the unique distance plays a great role for us to have a better patient experience and without suction loss. That's the best thing. Centration options and recentration after docking without the need to release the suction, cyclotortion compensation, low pulse energy with high repetition rate, and the vent channels which are formed along with the creation of the anterior and posterior lenticule surface decreases the OBL formation, less ocular damage, and faster visual healing. The guiding incisions and tunnels along with the OCT helps us in various ways. Finally, the lenticule geometry. The lenticule trajectory is made here for the resection. There's an incorporation of the Q factor which helps us to respect the preoperative and postoperative corneal surface. And the lenticule profile as such has a very tapering ends at the peripheral without the side cut, which ensures that the effective optical zone, the functional optical zone, is quite large, which helps us in decreasing the spherical aberration, which helps in the better visual quality in low light illuminations. CLEAR Zima platform as such is a mobile device, small footprint, so it doesn't need much space in your OT, and it is a multi-use laser. Apart from the CLEAR, which is used for the CLEX, it can design a flap, femtosecond flap. It can also be used to design intracorneal ring segments used in therapeutic keratoplasties, and with a different patient interface, femto-assisted cataract surgery can also be planned using this machine. With this, I say that amongst the available CLEX platform, the Zima CLEAR is the best. Thank you.
Thank you very much. That was very convincing indeed. So we now are able to tell, especially for the users here who are not familiar with both the VisuMax and the Zima system, now you can tell the differences and the advantages of each. Okay, next up, who are we going to have next? Rahul,
Yeah,
is it?
sure. So we will have the next talk for the next KLX technology that is there, which is the smart site. And to debate about the smart site to be the best KLX technology of the future, we have Dr. Raul Paulo Henson, and he's going to talk to us and probably convince us of why he believes that the smart site is the best.
Good afternoon. I want to thank the APO Organizing Committee and Professor Marcus Ang for inviting me to share my short experience with the smart site. Is it the future of KLX? I'm Dr. Henson from the Philippines, Senior Refractive Surgeon of the LASIK Surgery Clinic in Angeles City, Philippines. No conflict of interest. So the Schrind AIOS femtosecond laser is a laser that can do femto-LASIK flaps, kerato-lenticular extraction via the smart site procedure, and also intracorneal ring segments. But today we're concerned about smart site. So we got the first Schrind AIOS in the Philippines last year, January 2024. So as you can see, I'm a pretty much novice surgeon compared to our panel. So I can try to convince you that because of my early experience, this is going to be the best femtosecond laser for lenticule surgery. So smart site, why? It is safe, precise, accurate, and there's comfort for the doctor and for the patient. So the indications, again, pretty much regular indications, -50 to -1250 of spherical or spherical equivalent, myopic astigmatism of up to -600. So why is it safe, precise, and accurate? Well, we have a semi-automated centration of the eye, which is the first generation centration. We had an objective treatment offset, an automated pupil recognition, which is going to be transferred to the laser. The cyclotorsion compensation during docking procedure is based on the data from Schrind diagnostic devices like Sirius, Sirius Plus, Paramis, and what we have now is the MS39. And the second generation centration is coming in a couple of months, which is called the Centrax. So the MS39, just a brief background, it's the latest spectral domain OCT and the placebo topography. It measures the detailed corneal layers. It gives precise representation of even the epithelium on the epithelium map, measuring even the dry eye before the procedure. It has excellent image quality of the anterior segment, which we shall show you later, and it has a good keratoconus screening factor. And lastly, it has precise centering and cyclotorsion correction for the AIOS during surgery and in the MRIs. So this is just a picture of the things that we can see in the MS39. No? But for me, the most important thing here is actually the detection of keratoconus. Here, okay? As you can see in the bottom left, you could see the classification of this patient as explicitly as keratoconus. So this patient is not good for any refractive surgery. So this is an example of a OCT before surgery. This is pre-op, as you can see, detailed representation of the cornea, anterior segment, the iris, and even a part of the lens. So in Schrind AIOS, the most important thing, it has three processes. Okay, the diagnosis, which comes from the MS39, the planning, which is actually automated, okay, by the MS39, and then we transfer this to the AIOS for treatment. Okay. So this is the view of our monitor during the docking. No? So this big circle is the pupil, and then you have a joystick, and you just place it on the small circle. Once you're near the cornea, it will turn into yellow. As you can see, it also corrects automatically the cyclotorsion, so no need to mark any marking. And then once you're actually have that green circle, okay, you can start the vacuum. Okay. The curved patient interface is also very comfortable for the patient. It reduces IOP due to low vacuum levels. It has good ECPI connection. You just click and go in the machine, and one PI size fits all the eyes. No need to two types of patient interface, and of course the patient comfort. So once you see that image on the left side, once you can see orange boxes, right? It's pretty simple. Once the orange boxes right here are green, then you can start the laser treatment, okay? So this is just how we dock the machine into the eye, the interface. As you can see, once the machine detects the pupil, it turns red, okay? And all you have to do is actually align it, and then once it's green, and once the vacuum is green, then you press vacuum and then the laser, okay? And then, so this is just how you dock the patient. No, this is just, I took a video on the lateral side of the patient. As you can see, it really docks the patient. It even presses the eye down. So it's actually almost impossible to undock the patient. But of course, we're not perfect. Syringe is not perfect. It can also undock, but because of this, there's less chance of suction loss. And as you can see here, inside the patient interface, the laser is there, you know, and you can see it will actually do some lasering. It's shaking. That's the posterior laser, and then after that, another shaking. If you could see in the patient interface, that's the anterior laser. Okay, and then after that, the incision, and then we undock. Okay.
I get what you're saying, yeah.
So this is just a magnified view of.
Makes sense.
Okay, so again, the red big dot is the pupil. You place it on the small dot, and once it's there, you can see it's already in the cornea surface. And once everything's green, this one in the float position is on the green. Then you press vacuum, and the vacuum is good. All three are green, and then you just press laser, and that's it. And then I'll show you later the probe. That's the probe that you saw in the patient interface. It's going to shake, okay? So once it shakes, that means it's already going to laser. This is the the posterior laser first. And then we'll start the anterior. I usually have a 135-degree incision because I'm right-handed, so it's easier for me to dissect the lenticule after the laser. So this is just a short video of how I do the lenticule. It's pretty slow because, again, I told you I've been doing this for only 1 year, but so far I'm happy. You know, as you can see, this patient has some black spots on the upper left corner. Okay. And then we just insert the, okay. So once we insert the cannula there in the posterior, and I just check the anterior. Okay, I think we should proceed. So anyway, lenticular extraction is just, so this is the topography with the MS-39. It's all well-centered with the pre-op 1 day, 1 week, and 1 month post-op, pretty much centered. And then this is the OCT pre-op and post-op. The upper is the 1 day post-op. You can see a small line. That's the interface, okay? And this is 1 year below. You can see a slight line, so it pretty much heals pretty good. So this is just the Centrax, no? The new generation centration. It's a sophisticated centration and active eye tracking system that offers a fully automated cycle torsion compensation together with an active compensation of residual docking error, meaning it compensates for the residual error actively post-docking. So if it docks and then it moves, you don't need to do anything. The Centrax will take care of it. So this is just how the customization of our parameters. Optical zone between 5.5 and 8. Cap thickness between 100 to 160, I usually use a 140. Incision width between 2 to 5, I use a 3 to 3.5. And then the cap diameter is around 6.5 to 9. And this is just a view of our of the monitor that we see during surgery. As you can see, it's complete. Okay, the right and the left, it has the lenticular parameters, the refraction, the corneal pre-op, incision parameters, pupil data, and even the cornea post-op. So why is the low dose concept? People talk about energy. You know, the low dose, the lower the dose, the minimal strain, the faster the recovery the next day. So critical here is the spot and track distance, which is our key factors for low dose concept, because energy is commonly confused with dose. Not necessarily you have low energy, you have low dose. Okay, the dose is the area over which the energy is delivered. Okay, so energy times 100 divided by track and distance, spot distance is the energy. So this is just an example. On the left side, there's low energy, 50 nanojoules. Track distance is pretty close, 2 and 1. But look at the dose, it's 2,500. While in Smart Sight, you have a high energy at 90 joules. However, the track distance and spot distance are pretty much more separate, and you have a lower dose. So in our machine, you can actually titrate this. Okay, we started with 100. Now our energy is 85 with a track distance of 5.1 and 3, and we have a low dose of 555, which is good because the dose should be around 400 to 800 so that you have less edema the next day after surgery. And lastly, the lenticule geometry is also important. No? In Smart Sight, the lenticule shape tapers out into a genuine transition zone. So there is no edge cut and no minimal thickness. While in others, on the image above, there's a minimum thickness and there's an edge cut. Okay, so why is this important? Because it reduces epithelial remodeling with less regression and has less chance of epithelial hyperplasia after surgery. So in conclusion, why is Smart Sight the future of KLX? Many factors, you know. It is safe, precise, and accurate because of the semi-automatic centration and cycle torsion correction, which is just the first generation, what we have now. It has automated pupil registration. The MS-39 diagnostics are very crucial during surgery because data from that will be input in the laser. Centrax will be a game changer because it will be the second generation centration. It's coming up soon. Even in a couple of months, we'll have it. And again, lenticule geometry, its advantages that I just said. And lastly, comfort for the patient and the surgeon, the dome-shaped docking PI, consistent vacuum, less suction loss, and then it's easy to dock for the novice surgeon like me, and the low-dose concept with less energy and less edema will give you more chance of 20/20 the next day. Thank you.
Thank you, Rahul. That was great. Thank you so much. So the next speaker, Rohit, is a bit behind time. So we're going to have a quick discussion while we wait for him for a bit. So what I wanted to do is go down the line. So we already heard from quite a few speakers. So what I wanted to hear is, so far, based on what you've heard so far, you know, all of us come from different practices. Some of us are in tertiary hospitals, public, private. Some of us are small practices. So I wanted to hear so far about, for example, what kind of technologies or systems have you used? What do you feel about these technologies? To have try and have an open, candid discussion about what has been discussed so far. So maybe we'll start with, back to Arvind. We'll put Arvind in the spot. So what systems have you used? Have you tried? Do you agree with what has been spoken so far on the advantages and disadvantages?
So far, I used two platforms, the VisualMax 500 and the Elita system. I think they're also very good in terms of the efficacy and safety of the procedure. But I think every femtosecond laser that differed, even with the same company, it depends greatly on the temperature and humidity variation and environment. I mean, so you have to adjust it in the very beginning. For example, for the VisualMax 500, I get used to maybe 100 of cases, so I know what patient will achieve the day after surgery. But with the newer machine, I think you still have some work to do. I mean, to optimize the energy, and according to, for example, just some speaker mentioned about the corneal anatomy or the geometry of the cornea. I think it's very important to adapt every machine. It's different from one machine to another, even from the same company.
So I think Dr. Rohit is here. So we'll go to the last technology that we are discussing here is going to be the silk. And Dr. Rohit is, as we all know, is a globally appreciated researcher. He has worked on many of such CLEX technologies in his own hospital and the lab. And he's going to today speak to us about why he believes silk is the future of CLEX compared to the other technologies. So over to you, Dr. Rohit. Thank you.
Thank you. And my talk today is about how the new lenticular procedures, the silk can be a future of CLEX procedures. I was also an investigator for silk, along with these are my other financial gain. One of the most important thing is when you talk about the technology is the comparison is a thief of joy. And I enjoy using AIOS, silk, and smile all equally well. I've not found a very complete machine yet, and I believe that we should look at every machine as what it is good in. I think smile also has things which are very, very good and also has something which is desirable. Same thing with silk. So when you look at the new generation of femtosecond lasers, the platforms which I'm going to speak today, you have now a different energy settings, you have different spots, you have different flat interfaces which you need to be aware of. And suddenly, after say 10, more than 15 years, we got this slide which confuses everybody. We had, when me and Vardhaman were using, we had only one Visumax 500 and nothing else. Every time we had a slide, we used to always compare with, say, Contura or one of the other platforms. Now, with this coming in, it's very challenging for clinicians because we have to be very good with what we are doing and what we're using. So, are we looking at a seamless precision here? And one important thing is, when you're looking at the silk here, it's fast. You're using a low energy spots. Your spot size is smaller. And there's no space between the spots. They're all touching to each other. And short laser pulse. There's all physics of it. But still, as the next generation or the present generation of silk users, we have to be aware of all this. How does it really work? This video clearly demonstrates the power of all this, what I just mentioned. We're used to doing procedures by dissecting. This is all it takes to do a procedure when you optimize everything according to the perfect setting. And just like a peeling or just like a Rexis. And that's what we all want from a laser machine. How do laser energy affect the wound healing? Because you can create any kind of optical system. You can create any kind of optical spots, energies. But ultimately, who guides the outcome is your biology. To understand that, we have to go hidden into the what a confocal microscopy tells us. For example, in these sites, these are your keratocytes. And you see that they're minimally disrupted. But when the keratocytes are disrupted by your energies, you create more of early changes of edema, or they try to convert themselves into a fibroblast. And these conversions have an impact on the quality of vision and thus have a very big impact on the wow effect. So many times it's not your refractive challenges, it's not your refractive nomograms which bothers you. It's that those patients who come to you saying that I just cannot see clearly. And you do a refraction, it's plano, there's absolutely no change. But confocal microscopy is close to 900 times magnified version of your slit lamp. So when you see this hidden, you know that there is something not right. So when you have a reduced, we call it as change on your keratocytes, then your recovery is faster. Now let's look at the numbers, the shaping. Elita was one of the first to talk about the shape, because the shape is, they believe that shape has many advantages. We worked on a modeling, and you can see that there's a difference between a biconvex and a plano-convex shapes. Now, many companies have their own uniqueness in shape. The shape, you can debate on it. I've had many times discussion with Professor George Mehta also on this, that once you remove this, the shape goes back to its original shape, and it doesn't really follow. It's only the lenticule which is like this. So I will come back to that later. But how does all this shape and other things performs in giving the delivery? It is giving you that optimal vision, what your Contura or one of your laser lenticule, the excimer lasers would give. But today is not just about 2020, it's about trying to give them the best quality of vision. So when you are dealing with very advanced level of changing the shape, and when your cornea is healing well, when you have a anterior and posterior part of your lenticule being the same, your collapse of your collagen fibrils, I believe, should be less. Again, this is more of a theoretical model which we are working on, and that will reduce your aberrations, and that's what this paper was published on. You have a power of cyclotorsion. It's not as integrated seamless like you have an AIOS, where you are eye connected with the MS39, or in your Zeiss 800 is connected to your the biometry machine, the IOL master. But here is still manual, but I'm sure over time this will also reach a stage. I'm sure they're working on this platforms. We worked on high astigmatism. These are the papers in review, and I found that I compared it with the data I had from the topo-guided treatments, and it's very similar to what I have achieved there with no topo connect onto this yet. So the most important thing which is very favorite to me is the power of corneal nerve regeneration, because this is very important, because when I compared the regeneration of confocal microscopy, all these papers are in some of them are in manuscript stage, some of them are in review, some of them have come back with comments. You can see that the regeneration is definitely faster. We are close to around 80 eyes now on this, and we feel that it has a potential to regenerate faster and a better nerve protection. And these are some metrics we worked on. For example, the corneal fiber length, the corneal fiber dimension, the density, and you can see that, I mean, it's both these procedures change the nerves. I'm not saying that silk has got absolutely no relationship with the corneal nerves. It does change, but the density of change is much lesser. And what's interesting is its recovery is much faster, because you don't really bother much on the nerve factors, which is, when you cut a nerve, the new nerve neurotropic factors needs to be added for it to grow. So that is, in that way, it's definitely much better. So there's always a debate that nerve protection means that there's no dry eye. In fact, there is very little link between nerves. There are links, but it's not directly linked that, the nerve versus dry eye. There's a lot more than just the nerve and more than the dry eye. It's about the symptoms, what the patient feels, and what not clinically seen. So what we did was, there are a lot of nociceptive-based questionnaires which is necessary to understand the nociceptive features, because neurotropic factors are driven by nociception also. So when you look at this, if you look at those nociceptive factors, the ones which come to your clinic for years together with some irritation, pain, stress, cold, cold intolerant, and multiple things, you can see that with silk, we found that it was much lesser compared to what we see with PRQ or LASIK. And both of them have very similar dry eye metrics. That means dry eye was not the factor here. It was the factors of nociception. So what factors drive the nociception is these channels which we see on the epithelial cells. And this is a diagram by one of my residents. It shows that the nociceptive factors which makes you happy after surgery, whether it's cataract or refractive, is driven by how these nerves have an impact on these channels. And if you don't disturb them, and if you don't disturb them to create a change, you probably will have a very, very comfortable time rather than ones who keep coming to you with multiple complaints. And one of the factors, I mean, there are a lot of companies now who are also working on how to improve the TRP M8 channels, because this is one which has a huge protectant against these nociceptive issues. So what we are trying to work on is whether these nerve protection have an impact on these channels, and these whether they have an impact on your quality of life. Because when you have less of nociception, that what brings you the quality of life in them. So this is the work in Vogue, and this is something which we have worked on dry eye, so that's why I'm just using this here. So healthy nerves, the nerves help in regeneration. The epithelium helps in regeneration, because when you have a very poor epithelium, that has a huge impact on your quality of vision, as seen by this ray tracing abrometer here. This is a case where you see that if you see that ray tracing here, and you can see that the ray tracing has created post-surgery epithelium refractive change, which is just vague. And this is a very unhappy patient. You can see that the huge center, but you see that when you have a pure green areas, that this is a refractive change gradient on the epithelial level after you're done with silk. And this is some changes with other lenticule procedures. You can see that how the epithelium is remodeled, how it's changing, because it's related to two things. One is the shape, and also probably the nerves. And this is what you see with silk, with such pure healing of epithelium. And this is what I feel is causing this epithelial hyperplasia change. With the interest of time, I will just I'll just skip to the last slide here. So outcomes are good. The shape definitely has its own way of how it's trying to recover. There was a slide which I wanted to show. It does reduce the biomechanics, but the recovery is also very fast, something similar to corneal nerves. And the whole reason I like it is that I can dissect it without actual real dissections, what we have seen with other procedures. Thank you.
Thank you very much. So that was fantastic. So now we have heard from 4 different speakers on the various technologies, and maybe to round things up, we'll invite Professor Jod Mehta from Singapore, to take us into the future, what he thinks or what we think is going to be the future of KLEX. And then you get to answer the question, which is the best KLEX. Last final word.
Thank you.
Okay, thanks, Marcus. So so I was asked to talk about what I thought was the future of KLEX. So the simple answer is basically I don't really know, but I'll just give you some ideas of what I think the technology has shown us, and has shown us basically how we can try to see into the future by where we are currently now and where we have to then basically compete with. And of course, we're all lucky as refractive surgeons that we have LASIK, which is a fantastic procedure, has excellent outcomes. And if we're going to try to match that, we then have to think how we're going to be able to do that with Lenticule, basically, technology as well. These are my disclosures as well. So as Arvind basically pointed out, the journey in relax surgery started almost about 15 to 17 years ago now, initially with the flex procedure that I started doing back in 2009, 2010, which was essentially a flat-based procedure where we peel the surface of the lenticule from the surface of the cornea itself and then put the flap back down, and then to basically SMILE, which came out in 2011, 2012, and really has become the dominant procedure now, and then you've seen over the years as a number of SMILE procedures has basically grown. Last year, as Achal basically mentioned, it was a significant year. In fact, there have been 10 million SMILE procedures performed around the world. And it's quite amazing, actually, to be frank, that you could get to 10 million. If you look at the curve over here on the left-hand side, you can see in the early days, you know, back in like between 1 million and 2 million, there's a huge number of years. And then there's been a suddenly exponential increase up to basically 10 million. Last year, I was part of a consortium that basically published guidelines that was published in ophthalmology, looking at an evidence-based outcome for KLEX surgery. And this is something for those of you who don't do basically KLEX at the moment, but interested to basically undertake this procedure. It was done at a Delphi panel of 44 KLEX surgeons. And essentially what we tried to do was to come up with guidelines, basically both for preoperative assessment of patients, intraoperative management, management of complication, and looking at basically postoperative outcomes. And this paper basically analyzes all the viewpoints from many surgeons around the world and basically how they basically manage KLEX as well. And really this applies to all platforms, whichever ones that you have. If we look at more recent outcomes, and systematic reviews is a very good way of basically doing this, as some of the authors, some of the previous speakers have mentioned, you know, there's overwhelming evidence that you do seem to get less fair collaboration with lenticule procedures, but higher vertical and horizontal coma itself. And one of the variabilities in this is really related to centration and torsional control, which is one of the big limitations of first generation procedures. But we learned a lot basically about the first generation procedures on the left-hand side with respect to better ocular surface rehabilitation compared to basically LASIK, better biomechanics, especially in moderate to higher degrees of myopia. We know from evidence in the literature there's better long-term stability in lenticule extraction patients compared to basic LASIK, especially again for moderate to higher degrees of myopia. And you know, the best surgeons are able to get equivalent results between LASIK and basically lenticule extraction as well. But there are many things that we wanted on our wish list that you can see on the right-hand side over here if we really want this procedure to supply. And you've heard from all the speakers about the different lasers now that are available on the market, which is what our second generation procedures are currently as well. This editorial I wrote in JCRS basically talks a little bit about this and about one of the things that we basically wanted itself and what were the requests for basically second generation procedures, and really increasing the ability to increase a larger refractive range is basically important. But there are one or two things that I think that I'll highlight at the bottom over here and show you how I think it's possible to basically do this. We need to really think about, are we going to be able to do topography guided treatment? And this is what to me is one of the massive advantages of an excimer laser, able to really match your topography with basically the profile of the excimer beam. So is this possible with current lenticule extraction technology? This table is quite busy, but you see the ones that I basically highlighted. Talks a lot of detail about the different specifications on the machine, but the key features are really the ones that I've highlighted: energy, lenticule basically creation, shape, interface, docking centration control, and fully topographical link itself. And these are some of the big differentiation factors between the different machines. The reason why basically they differentiated itself is really down to the speed, but the concepts of basically photo disruption itself, okay? When you're looking at basically how photo disruption occurs with respect to cutting, it's like almost using a laser or a laser knife when you're using the Zima or the J&J machine in order to basically create a resection plane into the corneal tissue itself, while the ATOS and the VisuMax basically is still using a cavitation-driven basically focal point itself in order to basically create a plane into the surface. Now, you can think about this, you know, it's like thinking about, you know, having 1 gram of butter or 1 gram of sand or a 1 gram basically stone. If I drop the 1 gram of stone on your foot, you'll certainly basically know about it. If I drop 1 gram of sand or grains onto your foot, you're probably going to not feel it as it's trickling down itself. The quantitative mass, if you're looking at dosing as a parameter, is exactly the same. But of course, the effect is completely different. Okay, so physics is not the same as biology, and it's important to understand the effect on the tissue, whether with a response, likewise, as opposed to the effect of basically of a mass itself when you're using pure mathematics from this itself. And in JRS in January, I wrote an editorial with Holger to talk about this in a bit more detail. The other thing to understand is that lasers use basically nonlinear absorption. It's not a linear coefficient, so it's not the fact that you basically have it's not a fact that you have a little bit of an effect or you don't have an effect at all. It's an all or nothing effect itself. And this is going to basically affect your energy settings itself when you're doing the laser. Also, the ability to basically track your laser pulses as they're basically being created across the surface is really, really important, especially if you're going to think about doing topography guided profiles. And I'll mention this near the end of my talk. One of the other obvious things is basically applanation curves. And you can see two of the lasers uses curved applanation, and one of the lasers basically uses a flat applanation approach over here. And if you look at the schematic on the right side, initially it sounds a bit crazy why you'd use a flat applanator if you're going to cut a lenticule itself. But actually, when you look at basically the focal point over here across the surface, this is an example basically using the Alita, but I could have shown you an example using the Zima as well. You can see actually you form a very even focal plane across the surface when you're comparing this example over here compared to a curved applanator where you're finding an individual part itself. Okay, and the initial thinking that the cornea is obviously curved, of course, but every cornea has a different level of curvature. And you saw from the previous speaker, this is just that when I was using the AIOS to do a case in Nepal, you can see here that irrespective of what curvature you have, you're going to basically get folds in the cornea itself. And this graph on the left-hand side, done by Thea Siler's group, shows you the effect of posterior folds with respect to the curvature of the cornea itself. So that's going to happen anyway. It doesn't matter, and there is a way out of this, and I'll show you in my last slide how you can get out of this stuff. But on any current system, you're going to basically get some level of basically applanation. Another way of looking at this is basically looking at force on the surface itself. And engineers use finite element model analysis to understand force, and you can see this with the force distribution of stress on this aeroplane wing as well. Now, if you basically apply this to the cornea and you look at this in a little bit more detail, you can see that with any flat applanation system itself, actually you get a very even stress across the whole of the corneal surface itself. And in fact, the stress occurs where the suction is at the edge. If you look very closely over here, you can see it's slightly red on the surface over here, where basically the applanation cone is on the surface. And so what it means is that whatever laser we're currently doing to do lenticle extraction, you're going to get some sort of stress induced on the surface. The question is basically a variation in the amount itself. But again, if you're going to try to do topography guided treatment, we need to think of a way of getting around this basically going forwards. The procedures themselves with respect to how the lenticules are basically formed, you can see two distinctive kind of procedures. On the top ones, essentially using Archimedes spiral. On the new software that we have on the Zima now, we're using a combination of Archimedes spiral and basically raster, and that cuts down basically the time of basically cutting, and so far the results for that have been very good. At the bottom, you'll see a Newtonian swinging pendulum, which is basically on the Alita system. Again, the advantage of the Archimedes spiral lasers is that basically if you do get suction break from there itself, it's a lot easier to basically pick that up and then basically complete the procedure itself, as opposed to a Newtonian swinging pendulum, which the laser accurately measures the pulse as you basically track it across the surface, which is a great thing to basically be able to have. But the disadvantage is if you do get suction break, it's very difficult to pick up the rest of the lenticle cut if you're basically going to have a swing a laser pulse as well. And the speakers spoke about centration. You can get good centration comparative to basically LASIK. This is an RCT that we did in Singapore almost about 6-7 years ago now, and the results are almost exactly the same when you basically study the centration of the optical zones or functional optical zones between LASIK and SMILE. But that's not reality, right? In reality, if you really want a lot of people to do a procedure, you need to get every single surgeon being able to basically do the centration itself, and ideally this needs to basically be fully automated. All the current laser systems allow us to currently do this, either basically by having some control with centration and torsion, as you heard from the speakers, either with the VisuMax 800 Pro, with the Centraline and Oculine, or with basically Clear and SMILE. You can move the lenticule across the screen. Previously, it was semi-automated. Now the machine basically picks this up, and soon this will basically be fully automated to the system itself. And some of these are linking to tomographers, and I think this is the exciting thing itself. The lasers that are linking this to a topography, a full basically tomography unit, such as with Clear, with Schwind, and also with with Alita, actually you will have some advantages basically in the future with this technology itself. With the VisuMax, we link this basically to the IOL master, so it'll pick up your torsion and centration control, but it's not actually linked to the full Zeiss basically tomographer itself. So what I think about second generation procedures itself, well, I think that basically for most of our procedures that we need to do, actually most of the second generation will do fully automated control once we have all the links into place. Obviously, we'll see suction loss rates basically going down, either with the faster layers or higher levels of suction. I think it will reduce the learning curve, and we'll see that 10 million jumping up to probably 20 million in a shortened time period itself. But I think that if we really want to do a topography-guided treatment, the two caveats of this itself is that you must have a lenticule that is symmetrical on the anterior and the posterior surface itself, because otherwise the biomechanical stress response, once the lenticule basically removed, will give you an uneven arc length. And you can see this in the I've highlighted this here in our article itself when we discuss this in a little bit more detail itself, because the lenticule surfaces have to basically be even. The second caveat from this is that you need to do this in a non-applanating surface. And in fact, this has already been done from this research paper back almost 10 years ago that I could find. This was done in porcine eyes, where essentially they created a lenticule on the surface over here, and this was basically done without touching the corneal surface, done between an air and basically liquid interface. And one of the interesting things from this paper that was done on porcine eyes, and some of these pictures over here you can see with the smooth quality of the SEM, if you look at the minimum pulse energy, you can see the radial and the axial distance with respect to the accuracy of the spot spacing basically comes together at the lower pulse energies itself. So you need to have that combination of lower pulse, liquid applanation basically system itself, and the ability for the laser to scan at every single pulse itself. And some of the lasers now already basically can do that itself. And this would allow us to really have a topography guided lenticular extraction procedure itself for the future as well. Thank you for your attention.
Thank you very much, George. So while you're still on the podium, we're going to go down the line since you're there. So now that obviously we did this kind of format more for sharing and more for experience, in your opinion, what else? A lot of speakers spoke about first generation, and a lot of the technologies have stepped up for the second generation.
Yeah.
What, apart from topography guided, what else do you think is needed to improve KLX even further?
Yeah. So I mean, you're going to have so you have to expand the range, right? You cannot just have it purely myopic, right? So I think that having an expanded range is a massive advantage. And like Achal said, it's only available on one system currently now as well, right? Some of the limitations of doing a hyperopic correction is getting that lenticle. Lenticle is much bigger, because the optical zone is basically bigger. So there are some challenges with that. Your time basically may be longer itself. I mean, some of the lasers now, if you can alter between Archimedes spiral and raster, you can cut the basically timing down, but that might be something coming into the future as well. So you definitely have to do hyperopic correction, mixed astigmatism correction itself. Topography guide treatment, I know it's not a lot of patients, but there's certainly some patients that basically need it. And the appeal is basically there to be able to do this with a laser system. But you need to scan. So currently when I use the Elita and I use the Zima, both of them can scan a single individual pulse rate itself, okay? But, to be able to scan that onto the corneal surface and to do it without applanating. As soon as you applanate, I feel terrible that Vagina, I took that picture. That's not your picture, by the way. That was a picture from somebody else giving an ATOS talk. So I took it, actually, I took it in Taiwan. But I wanted to show the fact that it doesn't matter which laser you use, you're going to basically induce basically those folds itself. And people initially thought, well, I don't want to use a flat applanator because the folds are basically worse. But I think the answer is to go to liquid, to basically use a lenticule that has the same symmetrical pattern on the anterior and the posterior surface itself, whether it's a tadpole shape or whatever it will basically be, and the laser must basically be able to scan individual pulses, and that is certainly doable when you're basically putting the applanation down if you have the laser control linked to a tomography unit. So you must have that full tomography. Unfortunately, just linking to our master will not be good enough because you need to have that shape to basically follow the shape on the cornea.
And we're maybe we can get Rohit to comment on this as well, because I think we're in Asia, and of course we have a lot of high myopia, so we have high treatments. So which of the KLX technologies, I mean, shouldn't we strive for a KLX technology that removes less tissue? Because it seems like we're moving more tissue compared to LASIK. Well, sometimes.
Not always, but what I compared is, I think ATOS has, I think among the lot it uses not too much, but maybe a little less than the other technologies. But it differs. Sometimes you are doing a cylinders, Elita may be having a lesser ones, but it's not very not always that you have the same machine using more of thing.
Yeah, I mean, the main thing about the high myopia is three things really. It's more, it's not, it's if you can get round with optical effect with the amount of tissue you're removing. The second thing is the nerve recovery. High myopes definitely have more spherical aberration reduction, and they definitely had delayed recovery. But I think those are the things that we can work on to improve. So you can do high myopes and give them the same result as basically somebody who's like -2, -3 and stuff. And that's why it's important in the literature that it's not biased towards the low myopia. If these guys all do really well, it's always the slightly older age group that basically, or the high myopes that do worse, and we know that. But you know, you need to basically compare an apple to an apple to really look at the outcomes.
Thanks, John. So I'd like to go down the line, maybe Anchal next. You know, I also want to talk about, we talked about clinical outcomes and a lot about, you know, long-term stability, effect on nerve regeneration. But I think adoption of technology also is highly influenced by surgeon adoption. So ease, Rohit talked about ease of lenticule extraction, but also interface. So maybe you can share a little bit about, first of all, apart from what you spoke on, do you have experience with other technologies, and how important is ease of, you know, the technology, not just the docking, but also the laser, the speed, and also the lenticule dissection? How much of it is going to influence adoption from a surgeon's perspective?
I think that's been the rate limiting step, or one of the rate limiting steps is the challenges with the technique itself, because it's definitely a little bit more surgeon dependent and a little bit more technique dependent. And that's where you're needing to optimize everything, like your energy settings and, you know, balancing that against the ease of dissection. I personally have mainly experience with the VisuMax, but I did, in a wet lab setting, try the Elita, and so there's definitely differences, and I can't speak to the visual results from the Elita, but they do look very good. So, but I think it's really about optimizing the energy in your hands as to what's the best balance between not making it too challenging and then running into complications with the technique versus what you're aiming for with your visual results. And there's a balance there, and I think there's definitely a learning curve. I do think that a little bit of corneal surgical experience is helpful with the technique, and I think that that's why it's sort of more readily adopted by people who are also trained in corneal surgery, more so than just so I think there's definitely those sorts of issues. But I must say that in terms of offering it to patients, from changing from the 500 to 800, in making that a much more seamless experience and a very fast experience, it really has become my default procedure for myopia. So I think that that really does play into your selection and decision making. And lastly, I think if we can just make it just as predictable as LASIK, which I think there is some variation, as the other speakers alluded to, with the age, you know, as well as the level of myopia and other factors, I think corneal biomechanics. I think that will all, once that becomes very standard, that will really help in the wider adoption of the technique.
Yeah, so I think, yeah, absolutely well taken. And we all know that, like, because Smile or VisuMax was the first, it had the first mover advantage, and now you have the Smile Pro. But when it comes to the other platforms now with Clear, Silk, as well as with the Smart Side, so what I wanted to know with all the three users is that we already know with Smile, if you have a suction loss, you have the mechanism in which you can go ahead and you can actually plan the procedure with that corrective approach. But in Clear, then in, let's say in Silk and in Smart Side, how do you manage? Have you had suction losses, and how did you manage it? Yeah.
No. I've never had any suction losses with whatever I've done with Clear so far. But the advantages, as we already seen, it has the way it applanates, it has a very flat applanation with high vacuum system. It's just controlled. So literally you don't have much of suction loss. And I've personally not experienced. But you don't have a repair mechanism at present with the Clear platform.
So if in case somebody has a suction loss, then what will be your next step?
I believe the suction loss happens even before the lenticule would be there, because the patient, if they're going to be quite uncooperative, they might experience it even before we pass on the lenticule dissection. So we have to convert it to an excimer procedure.
Okay, we'll convert it into a flap maybe, and then go ahead. Yes, then I think, yes, please. Yeah.
We're talking about suction loss, right?
Yeah.
Okay, so I had a couple of suction losses. What happened in the first two were like, I, of course, abort the procedure, okay? And then we asked the patient to wait for like maybe an hour
Okay.
and then do an MS-39 diagnostics again and check the OCT. And if the OCT pre-op and after 1 hour is the same,
All right.
we do straight trans-PRK.
Okay, then you convert it into
Yeah,
advanced
you,
PRK
yeah,
procedure.
you can do it.
Sure.
But there's some parameters like, for example, in AIOS, like you first, if you were able to complete the posterior and then it breaks, there's a parameter. I did it once, so it's a difficult dissection.
Sure.
So once we also had, it broke suction loss, and then it's just the wound that's left.
Sure.
That one's fine. But once you break suction in the anterior posterior laser, during that laser part with the anterior and posterior, I would suggest to just do a trans-PRK like an hour after.
Okay. Wait
Yeah,
for an hour, make
after.
sure that everything is
But
back.
with the
to normal,
advantage
and then-
of the OCT before, the
Yes.
pre-op,
Right.
and the OCT
At
should
1 hour.
have the same exact
Right.
measurements. Yeah.
Do we have Dr. Rohit here? So maybe, Dr. Jodh, because you have used ELITA, in this case, if there is a suction loss, then how exactly we go about it?
Yeah, so I think that at the moment the plan is you just abort the procedure,
right.
and then you'd have to do either surface or basically LASIK back, bring them back
Or
again.
clear the flap. Yeah, sure. Thanks.
But you can do enhancement. I've done surface treatment for enhancements after
Enhancements,
ELITA.
right, right.
That's basically the same as with
Same,
the,
yeah.
there's
We
no
do
issue
expect
with
it
that.
to be the same, right? Right. So I think when me and Dr. Marcus were speaking about it, then I think we also spoke about the workflow, as he was saying, because that, as we were discussing again with you, is that because whenever you want to integrate any new technology in your system, you want to be not only efficient in terms of the clinical outcomes, but also efficient in terms of the time management. And so basically here, of course, I think with Clear, you have the advantage of this being a portable unit. You can put it into the, let's say, in a cataract operation theater and use the microscope. But with the Silk, what is the best way to get into the best workflow fashion and also with the Smart Sight? Yeah. Yeah. Right.
I thought it was for Silk. Again?
No, for both actually. So basically, I mean, with the Clear, we probably intuitively would understand that somebody can put this machine into a cataract OR and use this microscope to do the dissection. But with the Smart Sight, you do have an integrated microscope to do the dissection there and there
Yes,
itself.
yes.
So it is the workflow is exactly similar to a Smile Pro or Smile
Exactly.
technology.
So
Yeah.
I was able to, well, I was in the Lenticule Congress with Dr. Shetty
Right.
last year, and was able to do wet labs for almost all.
Right.
So I realized that ELITA, you really need another microscope for that. So
Right.
in terms of cost, that's already not good for, especially in the Philippines, because it's too expensive. Visumax would be good because it has an integrated microscope. Zimmer also you need another microscope. So
Right.
in terms of the economic side, we had to choose between Visumax or SmartSight. But when they introduced that Centrax and all these cyclotorsion automated and everything, it was just logical for me to get that. Since I'm a novice surgeon, it's easier to dock. So you don't need to mark, so it's like less stress on the doctor and less stress on the patient.
Right. Right. So, Dr. Jodh, last point being with the Silk, like what is the best way to get it into the workflow? Like we understand that it requires a microscope to do the dissection. So, in your system, you have two different ORs.
No, so when we
Again,
did it, the microscope was in the same, or we were using it was in the same OR as the laser, as the
Yeah,
femto,
right.
and then basically once the patient the bed just swings around, and
Right.
then you do the laser, and then basically it just swings back out under
Right.
the microscope. I
Right.
mean, it's similar to basically, to be fair, with Clear as well. I mean, for Clear,
Right.
you can
Yeah.
even do it under a excimer microscope, right? So
Right.
most people still have an excimer laser, right?
Yes.
So you
Yeah.
can just use the excimer laser,
Right.
and then basically do your Clear procedure
Yeah,
underneath that,
so
and then
these are-
move out. So you can use that
Right.
microscope.
So, these are some of the ways around to get the
Yeah.
workflow in much better way. Yeah, sure. Perfect. Right. Yeah, I think you can. Yeah.
Okay, great. I think we had a really good discussion. Do we have any questions from the floor or any comments? I think we had a really good objective discussion, in my opinion, about, first generation KLAX, what were the unmet needs, how the second generation of KLAX has really tried to meet those unmet needs, what further improvements we might need, but also you can see that, the adoption of KLAX as a technology is really surgeon dependent, how it affects our workflow, I will be devil's advocate about, I'm a huge advocate for patient experience. So there was a slide earlier on about speed, high vacuum suction versus low vacuum, applanation versus non-applanation, and the patient comfort during procedure, not just during the laser, but also the dissection. So I think each of the technologies gives a patient a different experience. And as we all know, as refractive surgeons, patient experience and word of mouth referrals is probably an important part of our practice. So I think this is something that we don't talk about often at meetings, but I think this is something that as surgeons we should be aware of. Having said that, devil's advocate is that if a patient has the same procedure in both eyes, he's not going to know the difference between silk or clear from a patient's perspective. But definitely, I think if the suction is high and the patient has, for example, suction loss, then suddenly, and then you've got to convert them to a surface ablation, that patient's experience is going to go down. Great. You have a question from the floor?
I just wanted to understand how would it be different from a private practitioner point of view to have flap-based procedures versus Calyx? So should we go ahead and go for these machines, or we're okay with our good results with flap-based procedures like femtosecond lasers? So really confused for last 6 months. So how does it make difference?
Those who are in private practice. I'm not in private practice, so I won't answer.
Yeah.
So
I think
for us, it makes a difference.
Right.
Different kind of marketing
so I think,
strategies are there.
you're with a group. Are you into the private practice? You can please, opine on this, please. Yeah, you can do it.
Definitely, we start our LASIK center started with, of course, LASIK excimer. I've been doing that for almost 25 years now. So I was actually skeptic about Lenticule, okay, which was introduced maybe 12, 13 years ago. So I'm not going to do this, I said. And then suddenly somebody introduced me again. I made the right choice. Now I bought a Lenticule machine. So for me, start first with an excimer. And then once you're very good with the excimer, they can jump on buying the what they call it, the Lenticule machine, okay? Because you know why? The excimer is a backup for.
So we have excimer with the femtosecond facility. So should we go ahead with the Lenticule at the moment, or should we wait for any third generation machines? Or so with
I think.
good-
What?
Which
Do you have a
femto do
femto
you
machine?
Yeah, I have a femto machine. Zimmer Z6.
Zimmer.
A Zimmer.
Z6.
Oh, there you go.
Z6.
I mean, like.
It's just a software upgradation then.
No, there's a hardware.
I think
upgradation.
the
Z6 to
Z8 will
Z8.
require
Z8
hardware.
okay.
Z8 requires.
Yeah, so I think, from the private practitioner point of view, I'll give you a small different perspective because when I started my practice in 2014, and ours was one of the, let's say, unique cases where on day one we went with Smile. So we and with excimer, of course, but so it depends on at core if your potency and specialty is in refractive surgery. If that is the case, then definitely that with all this discussion, KLX seems to be one of the most important thing that you should have in the armamentarium, and definitely it has a lot of advantages over the flap procedures, being most important thing being flapless, and the other advantages being, of course, as you know, is less dry and stuff like that. But of course, you need to know that it is going to require intensive investment. So you have to analyze, let's say, your own scenario in terms of how much you can invest, and at the core, how much of refractive surgeon are you in your practice. If you feel that it's a cataract practice and the refractive surgery is an add-on service, and you are doing decent volumes, then maybe let's say that it's not a must that you should go ahead with Calyx. But if at core you are a refractive surgeon, I think then you should have actually access to the end-to-end armamentarium. You should actually, all these technologies have their place. So the Calyx has a place, the Contura will have a place, the Surface has a place, ICL will have a place. So you should actually have a hang of all of them. It makes sense to invest. Definitely it is a higher investment. And you already are into femto and eczema. So I think next step definitely will be a Calyx. Yeah.
Would it help? And from patient point of view, the patients are practically they are helped shifting from femtosecond flap-based procedures to Calyx, or these are just theoretically we're thinking that the dry eye-based symptoms are less. So I am not sure because I've not used Calyx. So practically, I was just asking questions whether would it definitely help patients. Then we can definitely plan to invest.
Yeah. No, I think all these points that we are discussing are not theoretical. They're all definitely clinical and very much clinical. Definitely in terms of the patient's psychology as well, I'll very, very confidently tell you that patients intuitively understand that this is safer technology. And definitely in patient's mind, it is not difficult for them to understand that being flapless is the way to go. Yeah.
Thank you. Thank you so much.
Thanks.
I'll just add one more thing to that, which is I'm not sure if anyone else in your town or wherever you are is offering Calyx, and you know it does become a point of differentiation if you do it well. So I think that competition always, you know, all of that.
That's the
so
main problem at
I
the
think,
moment. Yes.
you know, and so it does give you an edge if you do it well.
All right.
Yeah.
Thank you so much.
Thank you. So with that, I think we should close the session. I'd like to thank all the speakers. I was just about to say that I had the previous session on KLX before, and one of the audience members just came out and said, so which is the machine I should buy? So I think that was the less controversial question. So thank you for that. So I'd like to thank the speakers for contributing all your fine wisdom, and I thank the audience for joining us today. Perhaps we can take a photo in the front. Thank you.